So previously we learned about opioids, and we're going to briefly touch on the management ideas that exist for managing opioid overdose. Thank you to Dr. Desai Braderick, who wrote this lecture for me. So we had talked about some of the adverse effects and had basically outlined the underlying mechanism for some of these adverse effects of opioid agonists. Recall that a lot of these opioid receptors are widely distributed throughout the CNS, and they modify pain perception, mood, regulate cardiovascular and respiratory activity. And so some of these side effects can be basically explained by the receptor expression of some of these opioid receptors throughout the body. So sedation, for example, can be attributed to the mu and the kappa receptors, euphoria from the mu receptors, dysphoria from the kappa receptors, constipation definitely are mu receptor dependent, urinary retention as well, mu receptor dependent, as well as respiratory depression. Respiratory depression is really kind of the one thing that we're going to really pay special attention to, which is largely driven by the mu receptor activity. And so when morphine or opioids are supplied in overdose, either accidentally or on purpose, and we'll talk about that in a minute, three things stick out. Respiratory depression, of course. If you examine the patient, their pupils will be pinpoint, very small, and the patient may be comatose. Okay. Other signs and symptoms include decreased bowel movements, if you were to listen. But you know, the best predictor of opioid toxicity or overdose is measuring respiratory rate. Okay, and so when looking at the patients, obviously if they're comatose and they're not breathing, it's a good indicator that they may have experienced a morphine or an opioid overdose. And so the good news is that there are drugs that can reverse it. And so we have opioid antagonists. Remember, the drugs that we've been talking about are mu opioid receptor agonists, and so the best way to get rid of an agonist is to supply an antagonist. Okay, and so these are drugs that attach to the receptor and compete with the opioid for that receptor. And this displacement of the opioid from this mu receptor can rapidly reverse the life-threatening respiratory depression. So there's pure antagonists such as naloxone. These are competitive blocking drugs. Naloxone inhibits the analgesic form that attaches to the receptors, but it doesn't do anything by itself. So you give naloxone to somebody who's walking around, it's not going to do anything. There's not going to be any effect. Naloxone really only works in the patient who's OD'd on opioids. Now, if you look in the literature, or if you're familiar clinically with some of the partial antagonists that are out there, butorphanol, nalbuphine, pentazocine, these have two actions on the respiratory system. These drugs can produce weak morphine-like effects in normal individuals, still resulting in some respiratory depression. In cases of acute opioid poisoning, however, partial antagonists, such as the drugs I just mentioned, can reverse respiratory depression. Okay, but really by far the best drug for reversing an opioid overdose is naloxone. Okay, and if we want to look at some of these other opioid antagonists that are summarized here, naloxone very rapidly reverses the respiratory depression, but it should be used with caution as it can precipitate withdrawal in opioid-dependent subjects. You should carefully titrate naloxone, basically to make it possible to reverse the depression without inducing a full withdrawal syndrome. And we'll talk about the withdrawal syndrome and the dependence liability in brain behavior and cognition. So the duration of activity of naloxone is quite short compared to the duration of action of a lot of these opioids. And so you have to repeatedly administer this drug or supply it with some type of continuous infusion. There's also been a formulation that's been out there now. It's a nasal spray why is this important? You can basically administer this drug quite readily in patients that are comatose and not breathing. You don't have to worry about injections and needles and so forth, and it just makes it super convenient. Naloxone is available as a daily administration. You can also get once monthly injections that are given intramuscularly. But of course, like EMTs and first responders, they're equipped with Narcan, and the spray is just so much easier because they don't have to fiddle around with needles, and they don't know the patient's medical history, and so there's bloodborne pathogens and so forth to be worried about. Naltrexone is available as a daily administration. It's really used with opioid dependence, and so we'll kind of table that drug for another discussion. Naloxone has been out there. That's basically marked for opioid-induced constipation. Remember, we said one of the major side effects to these drugs is constipation. And then, of course, naloxone is Narcan, as I had already mentioned. And so there's several mixed function opioids that are out there. Pentazocine, butorphanol, some of these others. A lot of these drugs are really used in the management of overcoming respiratory depression, but in patients that are clinically addicted. And so buprenorphine is a partial agonist or antagonist, but it has affinity for both the mu and the kappa receptors. If you give buprenorphine to a naive user, it has some analgesic activity, but in chronic users, it can actually precipitate withdrawal. You may have heard of Suboxone. Suboxone is a combination of buprenorphine and naloxone, and it's basically used in the treatment of drug dependence. And so this is where some of these drugs kind of fall into this category, but by and large, we're really kind of only focusing on naloxone. And I know many of you may have dabbled in research or have some clinical exposure, so you may be expecting me to go into more detail about these drugs, but for this particular patient group that we're talking about, patients who have overdosed on opioids, really the drug of choice is naloxone, whether it's nasal spray, IV, intramuscular. That's really the best choice. Some people have looked at activated charcoal, altering gastric emptying, hemodialysis. None of these are really recommended for an opioid patient who is poisoned or has overdosed. None of these things have really worked. By far, the best thing is really naloxone. If a patient literally just swallowed a whole bunch of codeine or Vicodin tablets, you could argue that going in there with like a gastric lavage to physically remove them would be a good idea. But you're probably not going to have the patient tell you that they just took a handful of pills, so that's probably not a real life situation. Other drugs can interact with these opioids, and we haven't gone through any of these drugs just yet, but understand that the sedative hypnotics, benzodiazepines like Valium, barbiturates, and alcohol, these really profoundly increase the CNS depression. And the reason I put it in here is because patients that OD on Vicodin or Tylenol number 3 or any of these opioid type compounds really are doing so either by accident, because they're addicted and they need to get that fix, or in the case of suicide, on purpose. And in the case of suicide, they often combine those opioids with some of the drugs on this list. And so that further kind of complicates things. And so understand that while we are going to talk about naloxone and how wonderful it is, it won't reverse some of these other drugs that may be on board. Okay. And so just as a brief summary, understand too that we looked at loperamide and its ability to treat diarrhea. We had talked about it in a previous case. And of course, dextromethorphan, which prevents the cough reflex. And so these are kind of other non-opioid drugs that exist that kind of operate through those receptors.